oocyte and sperm retrieval in IVF. Women undergoing transvaginal retrieval of oocytes should be offered conscious sedation because it is a safe and acceptable method of providing analgesia. The safe practice of administering sedative drugs published by the Academy of Medical Royal Colleges should be followed. Women who have developed at least 3 follicles before oocyte retrieval should not be offered follicle flushing because this procedure does not increase the number of oocytes retrieved or pregnancy rates, and it increases the duration of oocyte retrieval and associated pain. Surgical sperm recovery before ICSI may be performed using several different techniques depending on the pathology and wishes of the man. In all cases, facilities for cryopreservation of spermatozoa should be available. Assisted hatching is not recommended because it has not been shown to improve pregnancy rates. Embryo transfer strategies in IVF. Women undergoing IVF treatment should be offered ultrasound-guided embryo transfer because this improves pregnancy rates. Replacement of embryos into a uterine cavity with an endometrium of less than 5 mm thickness is unlikely to result in a pregnancy and is therefore not recommended. Women should be informed that bed rest of more than 20 minutes duration following embryo transfer does not improve the outcome of IVF. Evaluate embryo quality at both cleavage and blastocyst stages. According to the Association of Clinical Embryologists and UK National External Quality Assessment Service for Reproductive Science, Embryo and Blastocyst Grading Schematic. When considering the number of fresh or frozen embryos to transfer in a IVF treatment for women aged under 37 years, in the first full IVF cycle, use single embryo transfer. In the second full IVF cycle, use single embryo transfer if one or more top quality embryos are available. Consider using 2 embryos if no top quality embryos are available. In the third full IVF cycle, transfer no more than 2 embryos. For women aged 37 to 39 years, in the first and second full IVF cycle, use single embryo transfer if there are 1 or more top quality embryos. Consider double embryo transfer if there are no top quality embryos. In the third full IVF cycle, transfer no more than 2 embryos. For women aged 40 to 42 years, consider double embryo transfer. For women undergoing IVF treatment with donor eggs, use an embryo transfer strategy that is based on the age of the donor. No more than 2 embryos should be transferred during one cycle of IVF treatment. Where a top quality blastocyst is available, use single embryo transfer. When considering double embryo transfer, advise people of the risk of multiple pregnancies associated with this strategy. Offer cryopreservation to store any remaining good quality embryos after embryo transfer. Advise women who have regular ovulatory cycles that likelihood of a live birth after replacement of frozen thawed embryos is similar for embryos replaced during natural cycles and the hormone supplemented cycles. Luteal phase support after IVF. Offer women progesterone for luteal phase support after IVF. Do not routinely offer women human chorionic gonadotrophin, chorionic gonadotrophic for luteal phase support after IVF treatment because of the increased likelihood of ovarian hyperstimulation syndrome. Inform women undergoing IVF treatment that Evidence does not support continuing any form of treatment for luteal phase support beyond 8 weeks gestation. GIFT and ZIFT. There is insufficient evidence to recommend the use of GIFT or ZIFT in preference to IVF in couples with unexplained fertility problems or male factor fertility problems. Intracytoplasmic sperm injection. Indications for intracytoplasmic sperm injection. The recognized indications for treatment by ICSI include severe deficits in semen quality, obstructive azoospermia, non-obstructive azoospermia. In addition, treatment by ICSI should be considered for couples in whom a previous IVF treatment cycle has resulted in failed or very poor fertilization. Genetic issues and counseling. Before considering treatment by ICSI, people should undergo appropriate investigation both to establish a diagnosis and to enable informed discussion about the implications of treatment. Before treatment by ICSI, consideration should be given to relevant genetic issues. Where a specific genetic defect associated with male infertility is known or suspected, couples should be offered appropriate genetic counseling and testing. Where the indication for ICSI is a severe deficit of semen quality or non-obstructive azoospermia, the man's karyotype should be established. Men who are undergoing karyotype testing should be offered genetic counseling regarding the genetic abnormalities that may be detected. Testing for Y chromosome microdeletions should not be regarded as a routine investigation before ICSI. However, it is likely that a significant proportion of male infertility results from abnormalities of genes on the Y chromosome involved in the regulation of spermatogenesis, and couples should be informed of this. ICSI versus IVF. Couples should be informed that ICSI improves fertilization rates compared to IVF alone, but once fertilization is achieved, the pregnancy rate is no better than IVF. Donor insemination. Indications for donor insemination. The use of donor insemination is considered effective in managing fertility problems associated with the following conditions: obstructive azoospermia, non-obstructive azoospermia, severe deficits in semen quality in couples who do not wish to undergo ICSI. Donor insemination should be considered in conditions such as where there is a high risk of transmitting a genetic disorder to the offspring, where there is a high risk of transmitting infectious diseases to the offspring or woman from the man, severe rhesus iso immunization. Information and counseling. Couples should be offered information about the relative merits of ICSI and donor insemination in a context that allows equal access to both treatment options. Couples considering donor insemination should be offered counseling from someone who is independent of the treatment unit regarding all physical and psychological implications of treatment for themselves and potential children. Screening of sperm donors. Units undertaking semen donor recruitment and the cryopreservation of donor spermatozoa for treatment purposes should follow the UK guidelines for medical and laboratory screening of sperm, egg and embryo donors, describing the selection and screening of donors. All potential semen donors should be offered counseling from someone who is independent of the treatment unit regarding implication for themselves and their genetic children, including any potential children resulting from donated semen. Assessments to offer the woman before starting treatment by donor insemination for conditions listed in the recommendations 1.14.11 and 1.14.1.2. It is important to confirm that the woman is ovulating. Women with a history that is suggestive of tubal damage should be offered tubal assessment before treatment. Women with no risk factors in their history should be offered tubal assessment after 3 cycles if treatment by donor insemination has been unsuccessful. Intrauterine insemination versus intracervical insemination. Couples using donor sperm should be offered intrauterine insemination in preference to intracervical insemination because it improves pregnancy rates. Unstimulated versus stimulated donor insemination. Women who are ovulating regularly should be offered a minimum of 6 cycles of donor insemination without ovarian stimulation to reduce the risk of multiple pregnancy and its consequences. Oocyte donation. Indications for oocyte donation. The use of donor oocytes is considered effective in managing fertility problems associated with the following conditions: premature ovarian, gonadal dysgenesis including Turner syndrome, bilateral oophorectomy, ovarian failure following chemotherapy or radiotherapy, certain cases of IVF treatment failure. Oocyte donation should also be considered in certain cases where there is a high risk of transmitting a genetic disorder to the offspring. Screening of oocyte donors. Screening of oocyte donors. Before donation is undertaken, oocyte donors should be screened for both infectious and genetic diseases in accordance with the UK guidelines for the medical and laboratory screenings of sperm, egg and embryo donors. Oocyte donation and egg sharing. Oocyte donors should be offered information regarding the potential risks of ovarian stimulation and oocyte collection. Oocyte recipients and donors should be offered counseling from someone who is independent of the treatment unit regarding the physical and psychological implications of the treatment for themselves and their genetic children, including any potential children resulting from donated oocytes. All people considering participation in an egg sharing scheme should be counseled about its particular implications. People with cancer who wish to preserve fertility. Cryopreservation of semen, oocytes and embryos. When considering and using cryopreservation for people before starting chemotherapy or radiotherapy that is likely to affect their fertility, follow recommendations in the effects of cancer treatment on the reproductive functions. At diagnosis, the impact of the cancer and its treatment on future fertility should be discussed between the person diagnosed with cancer and their cancer team. When deciding to offer fertility preservation to people diagnosed with cancer, take into account the following factors: diagnosis, treatment plan, expected outcome of subsequent fertility treatment, prognosis of the cancer treatment, viability of the stored/post-thawed material. For cancer-related fertility preservation, do not apply the eligibility criteria used for conventional infertility treatment. Do not use a lower age limit for cryopreservation for fertility preservation in people diagnosed with cancer. Inform people diagnosed with cancer that the eligibility criteria used in conventional infertility treatment do not apply in the case of fertility cryopreservation provided by the NHS. However, those criteria will apply when it comes to using stored material for assisted conception in an NHS setting. When using cryopreservation or preserved fertility in people diagnosed with cancer use sperm, embryos, or oocytes. Offer sperm cryopreservation to men and adolescent boys who are preparing for medical treatment for cancer that is likely to make them infertile. Use freezing in liquid nitrogen vapor as the preferred cryopreservation technique for sperm. Offer oocyte or embryo cryopreservation as appropriate to women of reproductive age, including adolescent girls, who are preparing for medical treatment for cancer that is likely to make them infertile if they are well enough to undergo ovarian stimulation and egg collection, and this will not worsen their condition, and enough time is available before the start of their cancer treatment. In cryopreservation of oocyte and embryos, use vitrification instead of controlled rate freezing if the necessary equipment and expertise is available. Store cryopreserved material for an initial period of 10 years. Offer continued storage of cryopreserved sperm beyond 10 years to men who remain at the risk of significant infertility. Long-term safety of assisted reproductive technologies for women with infertility and their children. Long-term health outcomes of ovulation induction and ovarian stimulation. Give people who are considering ovulation induction or ovarian stimulation up-to-date information about the long-term health outcomes of these treatments. Inform women who are offered ovulation induction or ovarian stimulation that no direct association has been found between these treatments and invasive cancer, and no association has been found in the short to medium term between these treatments and adverse outcomes, including cancer in children born from ovulation induction, and information about long-term health outcomes in women and children is still awaited. Limit the use of ovulation induction or ovarian stimulation agents to the lowest effective dose and duration of use. Long-term health outcomes and safety of IVF. Give people who are considering IVF treatment with or without ICSI up-to-date information about the long-term health outcomes, including the consequences of multiple pregnancy of these treatments. Inform women that while the absolute risk of long-term adverse outcomes of IVF treatment with or without ICSI are low, a small increased risk of borderline ovarian tumors cannot be excluded. Inform people who are considering IVF treatment that the absolute risk of long-term adverse outcome in children born as a result of IVF are low. Limit drugs used for controlled ovarian stimulation in IVF treatment to the lowest effective dose and duration of use.